This is our patient, a 64-year-old woman who came to the emergency department mainly because of increasing shortness of breath and generalized weakness. A few days earlier, she started feeling breathless even while doing basic things like putting on her shoes. She has a known history of ischemic heart disease and has had multiple minor heart attacks in the past. She doesn't smoke or drink, but she does have a family history of cancer. Her mother had lung cancer and her father had colon cancer. On examination, her vital signs were slightly abnormal. Her blood pressure was elevated at 165 over 90, and her heart rate was 98. She had distended neck veins, and her heart's apical impulse was shifted to the side, which suggests her heart enlargement. Lung sounds revealed crackles at the bases, pointing to pulmonary congestion. Her abdomen was swollen and dull to percussion, and we could feel her liver 5 centimeters below the ribcage. Lastly, she had pitting edema on both legs, which is a clear sign of fluid overload due to the right-sided heart failure.
Let's explore the key differential diagnoses relevant to this clinical case. First one, we have the congestive heart failure, also known as CHF. This represents a complication of chronic ischemic heart disease resulting in fluid overload and signs of biventricular failure. Secondly, we have the colonic adenocarcinoma, a malignant tumor of the colon suggested by colonoscopy findings, a positive family history, and confirmed through histopathology. Then we have the iron deficiency anemia, often secondary to chronic gastrointestinal bleeding. This condition presents with microcytic, hypochromic anemia and a positive stool test. Then we have the lung carcinoma, considered here due to systematic symptoms and family history. While the chest x-ray is clear, a CT scan is essential to rule out early or metastatic disease. Lastly, we have the hepatic congestion or metastasis. May arise from right-sided heart failure or metastatic spread from colorectal cancer indicated by hepatomegaly and abdominal distension.
Now, let's talk about the abnormalities seen in the laboratory results of the patient. The chest X-ray, which shows signs of cardiomegaly, pulmonary congestion, and pleural effusion, indicating congestive heart failure, likely due to ischemic heart disease. A CT scan is recommended to rule out any chest mass. Here, the lab results suggest cardiorenal syndrome with an elevated creatinine 1, hypoalbuminemia likely from right heart failure, and a high BNP confirming heart failure. The reported calcium is likely an error if low. It may result renal dysfunction or chronic illness. Pallor weakness and a family history of colon cancer suggest occult GI bleeding likely from a colorectal cancer or polyps, requiring urgent colonoscopy. CBC shows microcytic anemia from chronic disease, thrombocytopenia due to splenomegaly and fluid overloaded, and a low reticulocyte count, indicating no active bleeding. Normal WBC and neutrophils with mild lymphocytosis suggest stress rather than infection, supporting a cardiogenic cause. Next, the peripheral blood film shows aniocytosis, hypochromia, and nucleated red blood cells, indicating anemia and bone marrow stress or hypoxia. Electrolytes reveal borderline hyponatremia at 135 millimolar per liter, suggesting early fluid retention and neurohormonal activation, linked to heart failure. Arterial blood gases confirm acute respiratory failure with acidemia, hypercapnia, and severe hypoxemia, pointing to impaired ventilation and gas exchange, mostly likely due to cardiogenic pulmonary edema consistent with decompensated heart failure.
Urinalysis results shows no evidence of proteinuria, glycosuria, or ketonuria, which effectively rules out intrinsic kidney disease and diabetes-related renal damage. There were slight elevations in both red and white blood cells, but these are clinically insignificant and not suggestive of infection. Overall, these findings may indicate early cardiorenal syndrome, likely secondary to the patient's ischemic heart disease and heart failure. Renal function should therefore be monitored closely. In cardiac enzyme report, the cardiac enzyme levels including CK, CKMB, LDH and troponin I are all within normal limits. Notably, there is no LDH flip, which means there is no biochemical evidence of an acute myocardial infarction. Taken together, these findings point toward chronic ischemic heart disease or decompensated heart failure rather than an acute myocardial infarction. For tumor marker test, carcinoembryonic antigen level is 6.2, which is elevated even for smokers. It commonly rises in colorectal cancer but can also be seen in lung, breast, or pancreatic cancers. Given the patient's age and family history, these findings indicate the need for urgent colonoscopy and oncologic assessment. The ECG result shows sinus tachycardia with non-specific ST changes, but no definitive signs of acute myocardial infarction. These findings may reflect ischemic strain, a possible non-ST elevation myocardial infarction, or myocardial stress secondary to underlying congestive heart failure. Ongoing monitoring is recommended to rule out unstable angina or evolving ischemia. Histopathological examination reveals multiple malignant characteristics, which are disorganized, crowded glandular architecture, hyperchromatic and pleomorphic nuclei, frequent mitotic figures. Importantly, there is clear evidence of invasion beyond the mucosa, consistent with at least a T1 stage lesion. In image 1, invasive pattern with loss of normal glandular structure can be seen. In image 2, back-to-back glands and marked nuclear pleomorphism is seen. And at last, in image 3, high mitotic activity and multilayered epithelium is seen. Together, these features are highly indicative of invasive adenocarcinoma. At last, in the colonoscopy, a 3.5 cm polypoid ulcerated mass in the ascending colon is seen. Lesions greater than 2.5 cm, especially those with ulceration, carry a significantly higher risk of malignancy. Given these features, the mass is highly suspicious for invasive adenocarcinoma. This patient has a significant family history of colorectal cancer and presents with fatigue, pallor, and weakness, which are classic signs of chronic iron deficiency anemia. Investigations show microcytic anemia, a positive stool occult blood test, and an elevated CA of 6.2. Colonoscopy revealed a 3.5 cm ulcerated mass and histology confirmed invasive adenocarcinoma. So, clinical, laboratory, and histological findings all point clearly to colonic adenocarcinoma.
Now we'll explain the pathophysiology of colon cancer. On the left, we see how it typically begins. It often starts as a small, benign polyp in the colon lining. Over time, due to the sequential genetic mutations such as in the APC, KRAS, and P53 genes, these cells become increasingly abnormal, grow uncontrollably, and eventually develop into an invasive cancer. On the right side, we see how this process applies to our patient. She had a 3.5 centimeter ulcerated mass in the ascending colon, which likely started as a polyp and slowly progressed. A tumor caused chronic blood loss, which explains her fatigue and iron deficiency anemia. Biopsy confirmed adenocarcinoma, showing irregular gland structure, abnormal nuclei, and high mitoic activity, all typical of malignancy.
Now let's review the main lab tests used in diagnosing colonic carcinoma. First, we have the stool tests. FOBT and FIT help detect hidden blood in the stool and early warning sign. Stool DNA tests identify mutations like KRAS and methylation changes linked to cancer. Secondly, we have the tissue and molecular tests. A biopsy from colonoscopy confirms adenocarcinoma. Molecular tests detect KRAS, NRAS, BRAF, and MSI, helping with prognosis and treatment planning. Lastly, we have the blood tests. CBC may show anemia from chronic bleeding, CEA tracks treatment and detects recurrence. Liver function tests may suggest metastasis.
Here, the patient has an iron deficiency anemia with low MCV and MCHC due to chronic GI blood loss confirmed by a positive fecal occult test. For the etiology, the chronic GI bleeding, likely from colorectal cancer or polyps, is the probable cause of iron deficiency anemia in the 64-year-old patient.
Now we'll cover the pathophysiology and etiology of cardiac failure in our patient. First, we know that heart failure means the heart can't pump blood effectively to meet the body's needs. It can affect the left side, right side, or both. In our patient's case, she had signs of both sides being affected. Crackles in the lungs and breathlessness suggest left-sided failure, while jugular vein distension, swollen legs, and an enlarged liver suggest right-sided failure. The underlying cause is ischemic heart disease. Her previous heart attacks damaged the heart muscle, reducing its contractility. As a result, blood started backing up in the lungs and systemic circulation. The body tries to compensate by retaining fluid and increasing heart rate, but this worsens the condition over time. That's why we see both symptoms and signs of decompensated chronic heart failure here.
Various possible treatments are there for this kind of condition. Localized colon cancer is treated with surgery, and in stage 3, adjuvant chemotherapy like Folfox reduces recurrence. Metastatic cases may need targeted drugs or immunotherapy. Palliative care is vital, and long term issues require a multidisciplinary approach.